To the ninth session of Foundation Work in Palliative Care. Today we are going to discuss on LGBTQIA+. We have an eminent faculty joining us today, Dr. L. Ramakrishnan. He's here. Welcome, Doctor. Welcome on board. It's my honor to introduce you here. Dr. L. Ramakrishnan, he's a public health professional and Vice President of SATI. SATI is a solidarity and action against the HIV infection in India. Is a public health non-profit focused on HIV, sexual health, reproductive health, and human rights issues. He earned his doctorate in 2000 from the University of Texas at Austin, USA, and has worked in health and human rights non-profit settings in USA and India. As of 2018, his portfolio includes support to the eMaitri Digital Health Initiative, to LGBTQIA+ inclusion programs, Empower, Access and Vistara, Project Sambuya, and Project Svedana. He has previously led programs on mainstreaming and decentralization of HIV/AIDS services, legal and social protection for PL-HIV, use of ICT to bridge information gaps, program evaluation and capacity building of implementers of health interventions. He is also involved in internal and external capacity building in areas of monitoring and evaluation, documentation, operation, research, and gender and sexuality. Welcome, Doctor. Welcome on board, and over to you.
Thank you so much. Is it possible to enable screen sharing?
Yes, sir. Just a minute. You have the sharing rights now. Please go on.
Okay. Can you see my screen?
Your screen is visible, sir.
Okay, great. So I will just try and change. Okay, great. Thank you very much to the organizers of this foundation course in palliative care. And it's a pleasure to be here among prospective providers of palliative care. So I will be walking you through basics of gender and sexuality and the relevant mental health issues that would be useful to know in case the palliative care, the person needing palliative care is from the LGBTIQ community. So I will be talking about the basic concepts related to gender, sexuality, and sex characteristics. I will talk about the stressors faced by the community from society and the mental health impact. I will discuss broadly the family and societal issues and their interaction with health as well as law, and then focus on some of the barriers that community members face in accessing palliative care and some of the best practices to consider while being a palliative care provider if you have a client who is from the LGBTIQA community, or if you don't know the gender or sexuality of the person for whom you're providing palliative care. So I see that among the participants, I'd like to see a small show of hands in terms of have you interacted with anybody from the LGBTIQA community before? Can you just do a small show of hands? You could do a show of hands using that hand raise button if possible. If that doesn't work, you can just actually physically show your hand. Yeah. I'm trying to see if anyone has their hands up. Okay, I do not see anyone with their hands up. Oh, I see 3 participants raise their hand. Okay, great. Would you be able to speak a little bit about the context in which you got to know or meet an LGBTIQ person? And host, could you unmute them so that they can speak? Please go ahead, introduce yourself and say a little bit. Yes, over to you. The 3 people who have their hand up.
Well, it was about in 1989, I came across the Dr. Bilada in Mumbai, who initiated the work among the eunuchs when they were found to be having HIV. And followed by that particular observation with Dr. Gilada, I then worked as a volunteer with the World Vision And so as a result of it, I have got to know a good number of people and I've interacted with them when they had to be given the right kind of a treatment to overcome their conditions.
Okay. Thank you very much, sir. Now could we go on to Rajni Nair?
Rajini ma'am, please unmute. Please, ma'am.
Please go ahead, ma'am. We cannot hear you.
Rajini ma'am, are you there?
Yeah, you can lower your camera a little bit so we can see. Yeah, there we go. Please go ahead. We cannot hear you though.
Ma'am, you are not audible.
Not audible at all. Now you're back to mute.
Ma'am, you are muted and you are not audible. Ma'am, please check the device's connection, ma'am. I think we can move to Vaishali, ma'am, while Rajini ma'am is getting her device ready.
Sure. Okay, please go ahead, Vaishali. Yeah.
Okay, so I have come across somebody while I was working as a violence counselor for the NGO Sneha at Sion Hospital, Mumbai. So we had done some training, and then actually one of the doctors who had attended the training came later on and spoke to me, and she opened up about her experience as a person who's actually male but born in a woman's body and all the complexities with it. So we had a few sessions, and it was really more of a learning experience for me because I didn't have any experience with that before. So all the challenges that the person has to face and the non-acceptance in the family and in society. So it was a lot of stuff I learned. It was more a learning for me.
How long ago was this? May I ask? Yeah.
About 3-4 years ago.
Okay. Okay. Great. Thank you for sharing that. How about Hadassah Chrysolite or Chrysolite? Sorry if I mispronounced your name.
So it's Hadissa. Good afternoon, everyone. So am I audible to everyone?
Yes, you are, yes.
Yeah. So my experience was I was interning at a mental hospital. I was in a master's student back then. So there was this teenager. He was around 15 to 16 years old, and his parents had brought him to the mental hospital because he was showing this characteristics of, he was slowly going towards the feminine side of it. Like he was wearing saris and he was dressing as a girl. And so he was, he felt trapped. He was a male, but he was a female trapped in a male body, let's say. And because the parents lacked awareness about all of this, and they thought that it's because he's been hanging out more with the women around in the area or something, and he's been influenced by them. So they brought him to the mental hospital to get him counseled. And that kid stayed around for like a month or two there. And the sad part of it all was that even the counselors there, instead of counseling him and saying that, okay, it's not something to be ashamed of if you identify as a female trapped in a male body. There are certain decisions you can take when you grow up after you're 18 or something like that. Instead, they started actually indirectly shaming him that, it's not appropriate for you being a boy. You're acting like a female. You shouldn't be doing these things. You shouldn't be going. He used to dress up as a lady, or wash his hair every Friday and apply the kumkum and all that, like women do down south every Friday. And he used to do that. So the counselors used to like try to stop him from doing all of that. And even they influenced me to like counsel him, to say that no, you also counsel him, saying that it's not appropriate for him to behave like that. But thankfully there were 2 other interns who were aware of such situations happening in other teams, and they gave him good counseling. And they said, once you grow up a little bit more, like you're 18 or something, and once maybe you can support yourself, then you can think of going for a sex change surgery or something. Get counseled, wait for a time, don't take a leap right now. But it's not something to be ashamed of, or it's not something that you should suppress. That's what the advice they gave him. And I still remember this case because even I was wrong at first when I saw him, and I was thinking that maybe he needs counseling for that. So I was wrong in that part. It happened around 3 years ago, 2019. And this is one case I really remember because of everything happening.
Yeah, okay. Thanks for sharing. You mentioned your perspective and the perspective of the counselors, other counselors there. How about the medical doctors, the psychiatrists and other people? How
So
did they
I
react?
think I am not aware what the psychiatrist told him, or I'm not even aware whether these counselors who was actually, it was like the psychiatrist was visiting every Saturday and Sunday, and most of the time only counselors used to stay. Even like in hospital, one counselor used to stay at night.
Yeah.
So I'm not aware whether he got a consultation with the psychiatrist, or these counselors were managing it themselves without getting a consultation from the psychiatrist. So I'm not aware of that situation. What
I
did they?
see. Okay. Thank you so much. Is Rajni Nair back to where we can hear her?
I think Mr. Samir had something to say.
Yeah. I sorry, was getting a call. So I have seen one case. It's not in a palliative setup, but wherein there was this woman that I was seeing, young 27-year-old. She herself had a sexual orientation where she was attracted to females, and in her body she was not comfortable. Like she would cut her hair short, and like and there were a lot of challenges as to getting not feeling accepted by the partner that she loved. And then there were like also how do I come out to my parents and tell that I have such and such interests. So all those kind of challenges were there.
Did you meet her in a clinical setting or a different kind of setting?
No, it was in a private setup, so not in a clinical setup. So I just wanted to sort of highlight that, yeah, there are a lot of challenges that they face,
Okay.
and sort of acceptance that they face.
Got it. Yeah, I see Rajni is back. Is your audio back as well?
I think she has some problems with her audio till now. She have shared her message in chat. I can read it out.
Please go ahead. Yeah.
This is Rajani here. Actually, I had a few colleagues from my earlier organization who belonged to the LGBT community. Their families and the co-workers were very accepting. Rajani says.
Okay, wonderful. So we've heard from 4 people. Anybody else would like to share? Even if you didn't have your hand up earlier, feel free to go ahead. Yeah, and I just want to hear if there's anybody here who, because of their cultural or religious or family or other related factors, have grown up with a very strong conviction that being LGBTIQA is sinful or immoral. It's quite fine to be, this is a safe space to also confront one's own, upbringing and notions of this. So is there anyone here who currently holds on or has held on for a long time to the notion that being LGBTIQ is sinful or immoral? Feel free to share. Or anyone who had that notion before and whose notions or understanding or impression changed.
Sir, can you please raise your sound a bit? Like there are messages coming like sound is too low.
Okay, sorry, it's there's rain and thunder here. So let me try putting myself on mute.
Okay, sir.
The question was, if any of you have in the past or in the present had views about being LGBTIQ.
So you're getting.
Yeah. So yeah, I was asking if anyone has in the past or in the present had views of being LGBTIQ being, immoral or sinful. And I'd just like to hear that.
We have a comment in the chat from Fakira Merchant saying, I was told by my religious mentor that it is against God's will. That do you have to say to this?
Yeah. What do you have to say to that? Yeah. So we will try to address this in the discussion that follows my session. So we definitely want to do it. One thing is that, as a care provider, specifically a palliative care provider, one is taught to support the client in his or her or their best interest. So sometimes this may require challenging one's own worldview, which may be counter to, for example, accepting people that are from the LGBTIQ community. And if you strongly feel that because of your belief system, you will not be able to provide palliative care or any other kind of care to a member of the community, it would be absolutely fine to recuse yourself from such a situation, and so that they are able to find somebody else who can support the client. So I say this to doctors also. There are some doctors who have very strong views against the LGBTQ community, and it may be difficult for them to come out and think. But in such a case, please feel free to refer to someone else. Yeah. Okay. So I'm going to get back to my screen. Just a second. Sorry. Okay. So in the overview of concepts, when we talk about LGBTIQ, we have one concept called sexuality, another concept called gender and gender identity, and another concept called sex characteristics. So I'm going to try and break these down in detail. So sexuality is, a combination of different aspects. One is your sexual orientation, who you are attracted to. Are you attracted to women? Are you attracted to men? Are you attracted to no one? Are you attracted to everyone? That would be your sexual orientation. Sexual behavior is who you actually have sex with, which is obviously influenced by many socio-cultural factors. If you are a priest in a religious denomination where you're supposed to be celibate, then even though you may have a sexual orientation towards men or women or both, you're expected to be celibate and not engage in sex with anyone. And this is called celibacy. And it's different from asexuality, where asexuality is a sexual orientation where you're attracted to nobody. So asexuality refers to lack of attraction, and celibacy or abstinence refers to not engaging in sexual behavior with anyone, which does not say anything about what your sexual orientation is. And finally, you have the notion of sexual identity, is whether you identify yourself as heterosexual or homosexual or gay or bisexual, etc. And these are expected to reflect your sexual orientation. But if you are in a society where your sexual orientation, let's say you're a woman who's only attracted to other women, and you are in a family and society that does not approve of it, you may not feel comfortable coming out and revealing that your sexual identity is homosexual or lesbian, right? So again, being able to identify as gay, lesbian, bisexual, transgender, etc. In this particular case, sexual orientation would be gay, lesbian, bisexual, asexual, and pansexual. We'll look at some of these in details. Also depends on whether the society gives you an environment that's conducive enough. One note here is the three may overlap, but they may also not overlap. I gave you an example of a person who may be heterosexual or homosexual, attracted to the same gender or other gender, but they may be, for religious reasons, not engaging in sex with anybody. Okay, that's an example where the sexual behavior is celibacy or abstinence, but the sexual orientation could be anything, homosexual or heterosexual or anything. You may also have an example of a person who is, let's say, a gay man, a man who is only attracted to other men and not to women, but society and the parents force this person to get married to a woman and have sex with her for procreation. So the person's behavior does not really reflect that person's orientation, and this can cause a lot of psychological distress. Similarly, a woman who is only attracted to other women, that's a lesbian, if she's forced to marry a man and engage sexually with him, that can also cause her a lot of distress, and it can be traumatic. Every act of sex can feel like rape. Yeah. But let's look at another example. Let's say a person is bisexual. They are attracted to men and women. It does not necessarily mean that they have to have sex with men and women to be sexually satisfied. They may be attracted to multiple genders, but they may have fallen in love with a particular individual of a particular gender. So let's say the person is a man and the man is attracted to men and women, but that person falls in love with a woman and engages with her sexually. It doesn't mean that he is changed from becoming bisexual to becoming heterosexual. His sexual orientation remains bisexual, but his sexual behavior is only towards that woman. Okay. So here are some common terms that I will go through. And these are typically terms of sexual identity, and they are meant to reflect a person's sexual orientation. But if that person is in a society which is non-accepting, the person may be forced to not identify as anything or to identify as heterosexual because that's the socially accepted sexuality. So gay is an identity corresponding to someone who's primarily or exclusively attracted to the same gender and also not attracted to the other gender. So if it's a man and that man is attracted to other men, that doesn't mean automatically he's gay. He could be gay or bisexual or pansexual. So the gay implies not only attraction to the same gender, but also lack of attraction to another gender. Bisexual is an identity that reflects significant attraction to multiple genders. It doesn't have to be 50-50 to be truly bisexual. It could be 60-40, 70-30, whatever. Okay. And here again, we're talking about bisexuality as a label corresponding to sexual orientation. Now, it's important to point out here that the medical field has a different understanding of bisexuality, which is only referred, they think of bisexuality only with respect to behavior. So if a man is having sex with men and women, they say that person is bisexual. But that person may actually not be bisexual. The person may be a gay man who was forced to marry a woman and have sex with a woman. So even though the behavior may be with women or with men and women, the orientation is not bisexual. So when we're talking about identities, we're talking in terms of what a person identifies as based on their orientation. Stop me if something is confusing after I go through this list, because I'm sure if this is the first time you're hearing some of these terms, there are bound to be confusions. So heterosexual is the term that I'm assuming would be the sexual identity of most of the people in this room. So it's an identity corresponding to primary attraction to the other gender. And statistics say that about 90% of a population is heterosexual. The other 10% may either be homosexual, which could be gay or lesbian, or bisexual. Okay. So heterosexual is the statistically common sexual orientation. It doesn't mean that you refer to heterosexual as normal people and non-heterosexual people as abnormal people. We're not talking about normality or an abnormality in a psychological or medical sense or a pathological sense. We are only talking about what is common in a statistical sense, numerical sense. A lesbian is a person who's a woman who is attracted to other women primarily and not attracted to other men. Okay. A pansexual person is very, it's very similar to bisexual, but sometimes people call themselves pansexual when they are attracted to other people independent of gender. So you will have people saying, it matters to me what's in their, between their ears, their mind and their intellect, and not what's between their legs. So a pansexual is different from bisexual in the sense that pansexual people may be attracted to individuals regardless of what their gender is. And a bisexual person is attracted to people as well as the gender aspect of that person. An asexual person is a person who is not interested in sexual relationships. They are not sexually attracted to people, though they may be romantically attracted to people. So, yeah, thanks. So an asexual person, again, may or may not be celibate, because celibacy or abstinence are about sexual behavior and not about orientation or identity. So there are people who refer to themselves as homoromantic asexuals, saying that they are romantically attracted to the same gender, but sexually attracted to nobody. There are also people who refer to themselves as aro-ace, which is aromantic asexual, saying that they're not romantically or sexually attracted to anyone. Okay, you may have a person who is a hetero-romantic asexual woman. She is romantically attracted to men, but not sexually attracted to men. Okay, so there are terms like that. And then there's an umbrella term called queer, which used to be a pejorative term with Hindi equivalents like chakka or Tamil equivalent like ombodu, etc., which was a pejorative term, but now the community has co-opted the term and used it as an umbrella term, saying I'm queer to mean I'm part of the LGBTI community and I do not identify with mainstream notions of who you're supposed to be attracted to, etc. Okay, so all of this, the last 2-3 slides were about sexuality. We looked at sexual orientation, who one's attracted to, sexual behavior, who one has sex with, and sexual identity, how one identifies. I'm going to pause here and ask people if they have any questions regarding what we've covered right now. We have not yet spoken about transgender. We have not yet spoken about intersex. That will come later. But with regard to sexual behavior, sexual orientation, and sexual identity, if you have any questions, please ask. I'm not able to see if anyone has their hands up.
Yeah, I'm here, Dr. Ramakrishnan.
Yeah.
Good evening, doctor. Like,
Good
I was a teacher before coming to Pallium. So I have a doubt, like, because I've seen many of, not many, but a few of my students claiming themselves to be bisexual. Lesbianism, of course, is there, but, I have this doubt was there within, inside me for quite some time now. Like, is it because they are mostly they were with girls that, they feel like, they are attracted and they're lesbians, and a few of them, as I said, they are claiming that they are bisexual. Can this be a passing phase, or like, is it going to be there with them? Because I've seen many of the parents, worried about it.
I'm guessing the parents are worried because they think their daughter will not get married to a man and make babies.
Exactly. Yes.
Yeah. So
No, but
again, if the person is calling themselves bisexual, there are 2 or 3 explanations. The most common and the most parsimonious explanation is that they are attracted to the same gender. Okay, meaning that they are attracted to other women and they are attracted to men. Okay, now, as I said earlier, it need not be that they are equally attracted to both. They could be significantly attracted to both, but it could be 20-80, it could be 30-70, etc., etc. But if they have felt that there is an attraction which is significant, then the label of bisexual is fine. Now, there are some people who are actually lesbian, but who feel that society will look down upon them more than if they said they are bisexual, because saying you're bisexual means you're preserving at least a little bit of connection with mainstream sexuality. So if somebody is coming out and they have not yet mustered the courage to come out as gay or as lesbian, they may think that bisexuality or calling oneself bisexual is a gentler foray into getting the other person used to the fact that they are different. But I would say the most, if you're going to take them at their word, the simplest explanation is, yes, they are attracted to men and women. Okay, but yes, if they are gay or lesbian, they may call themselves bisexual when they are coming out to other people, because they think it's a little more acceptable than coming out as gay or lesbian. The third thing is, I go into the world of pornography, where a lot of men find it very sexually arousing to see, two women having sex with each other. So for a woman to call herself bisexual actually makes her more desirable in the eyes of some men. And a lot of this is fed by pornography and stereotypes in pornography. Like if you look at pornographic movie titles, most of the pornographic movies with the word lesbian or bisexual in them are basically focused on men wanting to see 2 women, or two women and additional men in bed. But that's the third explanation, and it's I can't rule it out, especially in an urban setting and in a a college or something where everybody's talking and thinking about sex, etc. But the primary explanation would be that the person is attracted to men and women, and the ethical thing to do is to take their word for it and not ask them, are you sure this is the case, Or are you confused, or are you just doing it because it's trendy, or are you doing it so that you can attract some guys? The best thing is not to try and second guess them, but accept them for what they say they are, but make it clear that whether they are bisexual or asexual or heterosexual or lesbian or whatever, in any case, you're going to treat them the same, and you're not going to discriminate against them. So that would be the response of a provider.
Thank you, doctor.
Yeah. If you're a healthcare provider, you may need to ask additional questions about their sexual activity and potential exposure to infections, etc. But that's a different issue. Okay, so I'm going to pause with that. And any other questions? Yeah. Any other questions? Can I move on?
Yes, I think, doctor.
Okay, fine. So I've gone through this glossary, and again, I was referring to sexual identity, sexual behavior, and sexual orientation. Now I'm getting to gender. If any of you have had a course in the social sciences or humanities, you would have been taught that sex is biological and gender is social. And sure enough, the World Health Organization's official definition of gender refers to socially constructed roles, behaviors, and activities and attributes that a given society considers appropriate for men and women. So boys are expected by society to engage in manly activities, run around, climb trees, fall down, hit a cricket bat, be aggressive, get into fights with other guys, wear shirts and pants, not be interested in staying at home, not be interested in frocks, not be interested in pink color, not be interested in cooking, all these kinds of things. Whereas women are expected to be emotional, are expected to be more domestic. Women are expected to be, compliant. Women are expected to be interested in taking care of the family, etc. And a lot of these are social. They can vary from culture to culture. So if a man is wearing an item like lungi or a mundu or a kilt in Scotland, that is masculine enough in those cultures, but in any other culture, that will be seen as a feminine thing to wear something like a skirt, right? So there are cultural variation. Also, wearing a ear stud is a sign of masculinity in some societies, in some communities, but it's considered unmanly in other societies and communities. So what is gender appropriate is a little bit variable, but one common thing is if a person steps outside of what their culture deems appropriate, then they are harassed or punished or bullied. So a man who puts on, let's say, makeup, or a woman who is very assertive in the workplace, or a man who behaves in a quote unquote unmanly manner, or a woman who behaves in some quote unquote unwomanly manner, unfeminine manner, may be teased, may be harassed, etc. And all of this is particularly acute in school in early ages, because children can also be pretty cruel. So we will look at something called gender expression in a couple of slides from now. But broadly, we're going with gender. And so gender is a set of social attributes that correspond to what is expected of someone whose biological sex is male or someone whose biological sex is female. Now, apart from that, over the last 10-15 years, we have understood that in addition to what society considers gender appropriate, there is also something that an individual internally considers to be their gender. So the American Psychiatric Association defines gender identity as a person's deeply felt inherent sense of being a boy or a man or male, a girl, a woman or female, or an alternative gender. They may feel like I'm not a man or a woman, or they may feel I have characteristics of both man and woman. And this is called gender identity. And the important thing is that gender identity has been found to be innate. It's sometimes referred to as psychological gender or psychological sex. So a child who is born with male body parts and is assigned to be a male by the doctor delivering the child, who tells the parents you have a boy, and the parents bring up the child as a boy, but the child feels very strongly that they are not a boy, that they are a girl. So this child has a gender identity different from the gender assigned based on their biological sex. Similarly, a child may be biologically assigned female based on the body parts, but may have a strong sense that I'm a boy, not a girl. And this would be the child's gender identity. And again, this is the APA definition. And one thing to remember is that a gender identity is not the result of upbringing or watching too many movies or getting influenced by the media. It's an inherent sense. But how that child or adult expresses their gender identity may vary culturally. So a child who's assigned biologically male, but who feels like a girl, may choose to wear a sari or a churidar in an Indian context, may choose to wear a different set of clothing in a different cultural context. So this brings us to these terms. So transgender refers to gender identity, which is different from or contrary to gender assigned at birth based on biological sex. So in other words, if a child is born biologically male but feels like a girl, then such a child is transgender. A person who is not transgender is cisgender, the opposite. Now, within transgender, there may be individuals who consider themselves to be binary. So you may have somebody who's born assigned female, but who feels like a boy, or a child assigned male who feels like a girl. So boy and girl are binary transgender identities, but somebody can feel like neither. And such a transgender identity would be called non-binary. And the traditional, Hijra community, a lot of people consider themselves as third gender or as neither male nor female. And these are all examples of non-binary trans identity. One important point is earlier in a couple of slides ago, we spoke about sexual orientation, who one is attracted to. That is different from and independent of who one's gender identity or what one's gender identity is. So if you have a trans woman, that trans woman is basically a person who is assigned male, but who feels like a woman. But this says nothing about who that person is attracted to. The person may be attracted to men or women, both or neither, to other trans people, to non-trans people, to both or neither. So you cannot assume that a trans woman is necessarily attracted to men or a trans man is necessarily attracted to women. You can have a trans woman who's a lesbian, meaning that she is, her gender identity is that of a woman, even though her biological sex was male, and she is attracted to women. So someone may ask, if she is attracted to women, why can't she lead a life without, calling herself transgender? Why can't she live as a man attracted to women? The point here is gender identity is a very deeply inner feeling. So whether you feel like a woman or a man is independent of who you're attracted to. Now, in the Indian context, there are many local terms for transgender identities. So Nupi Manba is a term in Manipur for trans women. Nupa Manba is a term in Manipur for trans men. Hijra and Kinnar you would have heard in most of the Hindi-speaking part of the country. Tirunangai for trans women and Tirunambi for trans men are terms in Tamil Nadu. Aravani is an old term for Tirunangai. There are also other terms like gender fluid, where someone feels like their gender is not static. Agender, where a person feels like they don't belong to any gender. And non-binary, where a person feels like they do not identify as man or woman. Okay. Now, that's all about gender identity. Now I'm moving on to gender expression, and this is how the person expresses themselves. So even a child who is 4 years old, who may not have thought of themselves as transgender or cisgender or anything, may behave in a way that friends and peers and teachers and classmates and parents view as girlish, right? So a male child who behaves girlish in terms of who the child wants to hang out with, what games the child wants to play, etc., etc. So as I said before, a child who expresses gender differently, or even an adult who expresses gender differently, is teased and harassed. The rate of dropout for children who are gender non-conforming, in other words, children whose gender expression is different from the assigned gender, the dropout rate is much higher than for children who are not gender non-conforming or children who are gender conforming. So, which is why when we are doing sessions in education systems, we teach counselors and teachers and administrators to watch out, because children who are gender non-conforming have much higher rates of physical and sexual violence than the children who are gender conforming. Okay. So gender non-conformity is a broad term for an individual whose gender expression is not aligned with the gender expected of them based on by assigned sex. So to break this down with an example, a child who's assigned female based on her body parts is expected to act and behave like a girl, but that child's gender expression is more masculine. So such a child is gender non-conforming, and as an adult, this child may identify as transgender, but we don't know for sure. Okay, so what is important is that the child who is gender non-conforming faces a lot of bullying and violence, and therefore teachers and parents should make sure these children are not harassed or facing violence. And as an adult, a gender non-conforming children may identify as heterosexual, lesbian, gay, bisexual, or transgender. Only about 20% of gender non-conforming children in longitudinal studies have identified as transgender. The others have identified as something other than transgender. But it doesn't mean that a child who is gender non-conforming should be forced to behave in a conforming way. Okay. So again, gender non-conformity is not an identity. A child as young as 2 or 3 may express their gender in non-conforming ways, even though they may not be conscious of their gender identity or their sexuality. If there is time, there's a video to play. If not, I will share the link and you can watch that video later. Okay. Now, one last term while talking about gender is gender dysphoria. So gender dysphoria is a psychiatry term referring to someone who is very uncomfortable with what is expected of them based on their gender. So a female assigned child who not only says I'm a boy, but also feels really upset at being asked to grow her hair or to wear a skirt, and who prefers to urinate standing rather than sitting. All of these could be signs of gender dysphoria and merits investigation by a psychiatrist. If a child is having gender dysphoria, as opposed to merely being gender non-conforming, then the child is more likely to identify as trans while growing into adulthood. And gender dysphoric young people often have a desire to change their body through surgery, but there are also gender dysphoric people for whom if wearing the clothing that they feel comfortable with is enough, then they don't necessarily want to undergo surgery or hormone therapy. But if the individual wants to undergo surgery or hormone therapy, they need a letter from a psychiatrist certifying that they have gender dysphoria. Okay. In terms of terminology, the American Psychiatric Association and most of the psychiatrists in the private sector in India use the term gender dysphoria. People who follow the World Health Organization, ICD, now use the term gender incongruence. The old term was gender identity disorder, but since 2022 has been changed. Sorry, I made a mistake there. Changed to gender incongruence. Yeah, and so gender dysphoria diagnosis requires a psychiatrist to rule out other psychiatric conditions like schizophrenia. So there is a small chance an individual who has delusional disorder or schizophrenia may think of themselves as a different gender, whereas a person who is genuinely gender dysphoric does not have those psychiatric conditions, but the psychiatrist has to make that determination. Okay, before I get to sex, I'm going to stop here. We've had a lot of heavy duty concepts. We looked at gender identity, gender expression, and related non-conforming gender expression or gender non-conformity. And we looked at gender incongruence. We said that the word gender identity disorder is the old term of WHO, which is outdated and now being replaced by gender incongruence. So far with what I have said, are there any questions or clarifications? We also said that gender identity is independent of sexual orientation. So a trans man may be attracted to men or women or both or neither. A trans woman may be attracted to women or men or both or neither. Okay. Questions?
Hadash has raised her hand, sir.
Mhm.
Please
go
go
ahead.
on.
So,
Go ahead.
yes. So, my question is, like, usually now that we are getting awareness of this thing, that sometimes we put children in boxes which they don't fit into sometimes. So a lot of people are now coming up with this thing that we can use gender neutral terms for kids rather than using particular term for a girl child and for a male child, and bring them up in an environment which is not stereotype, like pink for girls, blue for boys, trucks for boys, dolls for girls. So my question is that, suppose when a child is grown up in such a situation where they're not told exactly, this is what is expected of you because you're a girl, and this is what is expected of you because you're a boy, does that in any way can contribute to a confusion in the child about their gender, or is it only inherent thing which will determine whether they feel comfortable with their gender or not? Matlab, can upbringing also confuse the kid? Because a lot of times the parents are like now being very woke. I'm sorry, like that's the word I get. So I have a question. It's a genuine question. Does that affect a child when they're growing up, when the parents don't want to term them as a girl or a boy?
An evidence-based question is that an evidence-based answer is that we don't have the evidence. But an anecdotal answer is that it may only affect the timing of the child or the decision of the child to come out and disclose to the family, and may not really influence their gender identity. If they are in a welcoming environment, they may be more likely to come out and state their their gender, but or they may even be more likely to experiment, but it's not likely to change the core of who they are. But if they are in a very stifling environment, they may be closeted, maybe even for the entire life. So it doesn't mean that they are not transgender, it's just that they have not been able to disclose. So but if you're looking at scientific evidence from longitudinal studies, I would say that there is no data. There is data on a different issue. There are studies in the West of children reared by parents who are, two men or two women, gay couples, lesbian couples, and by couples where one parent is transgender. And there is no evidence that the child's sexual orientation or gender identity is influenced by the parent's sexual orientation or gender identity. That's what we have in terms of medical evidence. Samir, go ahead. Samir, you had your hand up, but your mic off.
Sorry. So my question is, so you said that gender identity and sexual orientation can be independent of each other. So I was looking at it from the case that I had seen, and here the girl identified herself as a man who is trapped in a woman's body. So that would make her transgender, and then she had an orientation of attraction towards female. That would so lesbian. So that would
no, not lesbian, because lesbian implies their own gender is female. Their gender is their gender identity is that of a man. So I would say this is a heterosexual transgender man.
Heterosexual transgender man. Okay. Quite complicated.
The person identified as a woman, the person would be a homosexual woman or a lesbian.
Got it. But this is a like you said, it's a heterosexual
transgender man.
Can you repeat that? Transgender man.
Trans man is somebody who identifies as a man, though the assigned sex at birth is female. So that takes care of the transgender man part. And attracted to the other gender is attracted to women, because their gender is not only their gender identity is that of a man, right? So if they're a man attracted to woman, they're heterosexual.
I see. I see. Got it. Thank you.
Yeah. So anybody else before we move? We have time only until 4, right? Yeah. So I think I should go fast. Yeah. So maybe I'll just go back to sharing my screen and okay. Now, so I've talked about sexual orientation, identity, and behavior. I've talked about gender, gender identity, gender expression, gender nonconformity, and gender dysphoria. Now I'm going to talk about sex, about which I think all of us consider ourselves experts. And again, I'm not talking about sex as a behavior, I'm talking about sex as anatomy. So sex refers to the biological makeup of a person, and it's usually determined based on external body and internal body parts, hormones, tissues, and chromosomes. So when a child is born, the doctor will take a look at the child and say, it's a boy if it has a penis and scrotum, it's a girl if it has a vulva. The doctor will typically not probe into what is the chromosomal makeup or what is the hormonal makeup, right? But if you look at the hormones, there is an assumption that males will have more testosterone and less estrogen. Females will have more estrogens like estradiol and less testosterone. Genetically, if you look at the pattern of inheritance, females will have two X chromosomes and males will have one X and one Y chromosome. So, if a male that has a sperm with a Y chromosome fuses with an egg, then you get a male child. If a male sperm which has an X chromosome fuses with an egg, then you get a female child. So this is the pattern of determining sex in a biological sense. But the mistake we make is we assume that all of these are lined up. So if you have a male, the male will necessarily have an X and Y. The male as an adult will necessarily have more testosterone than estrogen. And the male will necessarily have these body parts of a external penis and scrotum, internal prostate, etc., etc. And a female will necessarily have XX. Female will necessarily have more estrogens and will necessarily have a vulva, vagina, cervix, uterus, ovaries, fallopian tube, etc. But this neat lining up doesn't always happen. So here is a range of 5 different phenotypes. So here are babies born with external body parts that look completely female, to body parts that look completely male, and a whole range of intermediary conditions. So this is a particular condition called androgen insensitivity syndrome, where the child has an XY chromosomal makeup, but during embryological development, the fetus does not respond to androgens. And if it does not respond to androgens completely, it is born with a female phenotype, and that is called CAIS, complete androgen insensitivity syndrome. If it's partial, you may get one of these forms. Okay, so this is an example of what is called an intersex condition, and the baby may look like this. The genitals may look something like this. So you can't tell whether it's a scrotum or labia. You can't tell if it's an overgrown clitoris or an underdeveloped penis, etc. Some intersex children are born with XXY, which is called Klinefelter syndrome, or just a single X, which is called Turner syndrome. And then we have androgen insensitivity, we have congenital adrenal hyperplasia, etc., etc. All of these were historically considered to be DSD, disorders of sexual development. Nowadays, we consider them to be DSD, differences in sexual development, because having these variations is much more common than formerly thought. Normally, we used to think that these are like very, very rare, 1 in 100,000, 1 in 1 million, etc. But as more and more data come and we realize that intersex variations can be as frequent as 1 in 100, the pathologizing term disorder has given way to the more neutral term difference, so DSD. So sex characteristics are sometimes visible at birth, where a child is born with ambiguous genitalia. Sometimes it may only be visible at puberty. So there's a child with genitalia that look completely female, okay? And the parents raise the child as a girl. But when the child is supposed to be entering puberty, the child does not menstruate, does not develop breasts. And the parents get very worried and take the child to a doctor who does a karyotyping and figures out that the person is actually XY with androgen insensitivity syndrome. Okay, so sometimes intersex characteristics are visible only at puberty, sometimes at birth, and sometimes not at all. The individual may go through life not knowing that they're intersex. Okay, now I'm again going to do a quick stop here if anybody has any questions. What I will say is historically, even within the medical establishment, doctors have confused between intersex and transgender. They think transgender people are born with body parts that are ambiguous. They use the term like hermaphrodite and pseudo-hermaphrodite and all that. But those are terms referring to intersex conditions and not to transgender. Okay, so intersex and transgender are not the same. Yeah, I'm going to quickly see if anyone has a question or a comment before moving on. Okay, I'm going back. So now I'm going to breeze through some slides. The most common, and I'm talking here about cultural and religious arguments, saying that LGBT people are not found in our culture. There are plenty of examples from our culture, from indigenous communities like in Manipur, where there are some communities untouched either by Hindu colonialism or British colonialism, where trans children are revered, are considered to have divine powers, etc. There are examples of men having sex with men and women having sex with women in sculptures and architecture, in temples, in mythology, etc., etc. And historically, it's been everything from the Kama Sutra to Charaka Samhita have mentions of same-sex behavior, transgender people, etc., etc. Very often, the punishment for such behaviors or identities or orientation happens only when the person refuses to get married or refuses to have children. If they don't refuse to get married or they don't refuse to have children, then very often people turn a blind eye to this. Sorry for being ableist, they ignore these things. There are other arguments that are advanced by scientists and doctors saying that, oh, this is unnatural behavior. And in fact, even the legal definition of Section 377, which is the British law that we imported in the 1850s, said this is against the order of nature. But now again, as scientists and biologists, we've discovered same-sex behavior and transgender expression in over 450 species of vertebrates and invertebrates. Everything from chimpanzees to swans to dolphins to penguins. So what are the problems facing the society, the LGBTIQ community? Society wants everybody to behave like a real man or real woman, get married, have children, preferably boy children, etc. And if you don't do this, you're in for trouble. As a child, you may be bullied at home, you may be bullied at school. All of this can lead to suicidal behaviors. Also, within the healthcare system, there's a very, very unethical practice. And now, since August of 2022, an illegal practice where a doctor will promise the parents that I can change your child from gay to straight or from transgender to cisgender or quote unquote normal. This has been outlawed now. So these systemic issues, negative attitudes towards homosexual people, bisexual people, and transgender people, and stigma and discrimination in school, in workplace settings, in healthcare settings, difficult experiences of coming out if they are in a very conservative family, social isolation, exclusion, and rejection, a child thinking I'm the only one like this, everybody else is different from me, can all lead to low self-esteem, depression, anxiety, including social anxiety, eating disorders, misusing substances, self-harm, suicidality, and other mental health problems. In this, there are data from adolescents who are gay, lesbian, and bisexual, where both the suicidal ideation as well as suicidal attempts are much greater than for adolescents who are not gay, lesbian, or bisexual. For transgender people, they have North American studies, 47% prevalence of suicide attempts, along with a lot of other horrifying statistics like 57% facing family rejection, 19% refused medical care, 19% experiencing homelessness, etc. These are large data sets with over 6,000 participants from North America. We don't have such quantitative data in the Indian context, but there is a lot of qualitative data talking about suicidal ideation, suicide attempts, etc. In the education context, children face verbal, physical, emotional, sexual violence, leading to psychosocial outcomes like isolation, lack of belonging, anxiety and depression, suicidal ideation that can lead to fall in grades, loss of interest in continuing school, increasingly becoming absent and dropping out. What does the law say? Since September 2018, it is no longer a crime to be in a same-sex relationship. And since 2014, transgender people have protection under the law. So this is from two very important Supreme Court verdicts. If you have questions about this, feel free to ask me or ping me. My email address will be here, and I can also share with you the PowerPoint if you'd like. Now, I want to talk a little bit about conversion therapy. The pioneer in opposing conversion therapy was Dr. K.S. Jacob from the Department of Psychiatry at Christian Medical College, at a time when a lot of his colleagues and people around the country, psychiatrists were telling parents that we can change your homosexual child, we can change your gender non-conforming child, we can change your transgender child. He and Dr. Satyanarayana from Mysore Medical College were both part of the Indian Journal of Psychiatry editorial board, and they have really advocated to healthcare providers not to try such conversion therapy because it's unethical. Last year, Madras High Court banned conversion therapy in Tamil Nadu and said that if a doctor practices it, you should revoke their license. The National Medical Commission last month actually classified conversion therapy by medical professionals, again, allopathy, not Siddha or anything, as a professional misconduct, and it has notified all the state medical councils. So please keep this in mind. I think one of the folks who spoke earlier said that as an intern, she saw counselors telling a trans person or a queer person to change. So that is something that is completely unethical. And if it was a doctor saying that, the doctor could lose their license. Unfortunately, the Rehabilitation Council of India or the other professional associations for social workers and psychologists have not banned it yet. So last couple of slides, I see it is 4, so I'm going to run, is that I've explained a lot of problems people have growing up LGBTIQ. It often results in being estranged from their birth families. And if they have relationships, these relationships other than man-woman relationship are not considered valid or legal. And there's a lot of data showing that in healthcare settings also, if a woman goes to a healthcare setting, if she goes to an OBGYN, the doctor will say, are you married? And this is the question that is supposed to uncover answers to her sexual behavior, her risk of various health conditions, etc. So if a woman is lesbian and she just says, I'm not married, the doctors will simply assume that she's not having sex, right? So there's a lot of indifference and sometimes hostility in healthcare settings. And in palliative care also, most of what we learn in palliative care is about individuals who have been raised in heteronormative setups, where they themselves are individuals who are attracted to the other gender, may have had a wife or husband who's ill or passed away. And you will always assume that in palliative care that there are caregivers from the biological family. This may not be the case if you're providing palliative care to somebody from the LGBTQIA community. So some of the best practices are, do not assume whether they are trans or gay or bisexual or lesbian based on their appearance or their behavior. You utilize respectful and sensitive ways to find out, if they're in a relationship, whether they have family support, if they have a partner, etc. And if you do this, again, there's data from a 2018 paper in oncological nursing that shows that if you follow these kinds of sensitive history taking, you can actually help the patient derive greater comfort level, higher overall healthcare satisfaction, improved alignment among patient, caregiver, and provider, better sense of well-being, and enhanced quality of care. Also, what we have seen so far, even though we rushed through it, is that there are a lot of stressors. What the family tells you, what society tells you, what school tells you, what people around you tell you. There's bias in the healthcare system. The doctors will just assume that you are heterosexual or you're not transgender. And a lot of people have faced bad experiences in healthcare settings, so they are afraid to even go see a doctor or tell them about problems. And even during COVID, for example, I know of a person a gay man who was admitted to intensive care and has had a male partner for the past 16 years, but was absolutely, that partner was not taken as a partner by the healthcare system, was not consulted in any healthcare decisions. And the parents of the gay man who had actually, ejected him from the family were asked to come and make decisions. So things like that happen quite a bit in healthcare settings. So whether you're talking about advanced care planning, etc., inquire about existing families of choice, relationship partners who are not recognized by law, and see how they can be included. Even if the legal system has its biases, there are some ways in which palliative care providers can work around the system. The Indian Mental Health Care Act is one of the first laws in the Indian context that allows people who are not legally married spouses or blood relatives to be nominated for, advanced care planning and those kinds of directives. But we hope that this will change over time. Also, if you are a palliative caregiver and you need to conduct a physical examination of a client, maybe that person is transgender, the person has not told people around that they're transgender, and they're afraid that if you give them a sponge bath or something like that, you will discover that they have body parts different from what you expect. And so even if you're doing a physical examination, etc., you openly discuss why you want to do the examination or why you want to provide other kinds of care that requires the person to disrobe. And you can ask the person, what do you call this body part? A person who's a trans man who has not had the financial resources to go for a surgery to remove his breasts may still feel very dysphoric about his breasts and even about using the word breast. So you may ask the person, what would you like me to refer this body part as? And the person may say chest. Okay, so things like that. So there is a lot of emerging literature around palliative care needs and strategies for the LGBTIQ population. And I'm happy you can go through these references and also reach out in case of further need. So I'm going to stop here. Let me see. I have another seminar that's starting now. But yeah, any quick questions? I'm going to type my email address in the chat.
Thank you, Doctor. Thank you for that wonderful session.
Yeah.
There are any questions?
About the question about it is told by my religious mentor that it's against God's will. So if you truly believe that, then simply remove yourself from an uncomfortable situation by recusing yourself from being a healthcare provider or a palliative care provider to that person. But that's all I can say for right now. If you want to know more about what the religious texts say, then look at, for example, biblical scholars and Quranic scholars who have actually interpreted religious texts in different ways. So, for example, the sins of Sodom and Gomorrah in the Old Testament, the biblical scholars have analyzed it and said that it's not actually homosexual behavior, but it is non-consensual rape of men by other men. So when we talk about LGBTIQ relationships, just like when we talk about heterosexual relationships, what is approved and what is not a crime is adults having consensual sex with each other or being in a consensual relationship with each other. But just like a man raping a woman is a crime, a man raping another man is also a crime in the eyes of the law. And some biblical scholars say that the crimes referred to in Sodom and Gomorrah are those of rape and not of consensual sex. So then if you have the time and the bandwidth to look at these scholarly sources, I can also share you some biblical as well as Quranic references. And my email is typed in there, so feel free to, oh, I'm typing it here, one second, sorry.
I have shared your email, sir, in the chat box.
Oh, okay, great. Thank you. Yeah, so can we close, or are there any final questions or feedback? Our time was until 4:30 or 4? I'm sorry, I forgot.
4:30, sir.
Oh, it's 4:30. Okay, then fine. Okay, then we are good. For some reason, I thought it was 4, but I'm just realizing now that my other seminar is also at 4:30, so we do have time. So I need to have raced through this. But yeah, we can aram say listen to some questions and some reflections. Please go ahead. Including people who may not have any questions, but want to reflect on any change in their thinking from what they had before they came to the session, or any further doubts that they have. Yeah, thank you, Shiny, Sarita, Robin, Gautam, everybody who's written in. Really appreciate your message. Musa, Biha, Preeti, yeah. Okay, someone has said, please elaborate on the new law of conversion. This has come in a direct message. So essentially, there is a body called the National Medical Commission. It was formerly the Medical Council of India, MCI. So in 2021, there was a verdict of the Madras High Court by a judge called Justice Anand Venkatesh, where a lesbian couple from the town of Madurai had run away from home because their parents were opposing their relationship and trying to force them to marry men. And they filed a case for asking for safety and protection from their parents and the police, because the police were also supporting the parents. So in that, in the interim orders given by Justice Anand Venkatesh, he actually himself wanted to learn more about the LGBTIQ community. So he consulted a psychologist, and he also met with people who are working in the field, I was also among them. And as a result of that, about a year ago, he gave an order. In that order, he spoke about how the police, the healthcare professionals, the teachers, everybody needs to be sensitized. The judges and lawyers also have to be sensitized on these issues. He understood that the MBBS and MD textbooks contain a lot of outdated information. For example, in the year 1990, the World Health Organization accepted that homosexuality is not a mental illness and removed homosexuality from the ICD, International Classification of Diseases. However, even until 2020, the MBBS books, especially in psychiatry, the Indian books, and in forensic medicines, and even like Shaw's textbook of gynecology, etc., they have content saying that this is a psychosocial disorder. So there are a lot of places where the Indian textbooks are just reprinted versions of old textbooks, and they have not actually modified it based on the science. So Justice Anand Venkatesh notified the National Medical Commission to change this, especially in the subjects of forensic medicine as well as psychiatry. And he also said that this practice of conversion therapy should be banned. The National Medical Commission took almost a year to respond, but they have now directed all the departments and directorates of medical education to change the MBBS and MD textbooks and to change the curriculum. The competency-based curriculum that MCI put out in 2019 also is riddled with errors in all of these subjects. It's not only forensic and psychiatry, it's also in pediatrics. We have an entire curriculum about pediatrics for medical students that only talks about adolescents developing attraction to opposite sex when they grow into adolescence. There's nothing about homosexuality or bisexuality, nothing about transgender identities. So all of this needs to be changed. Also, gynecology needs to be changed. It's not only women who have gynecological problems. There are trans men who have gynecological issues too. So the gynecologist, I'm working with a gynecologist, Dr. Prabha Swaminathan here in Chennai, and we are trying to revise the gynecological curriculum as we speak. So essentially, if an allopathic doctor, someone who's registered with the State Medical Council, does conversion therapy, then it will be classified as professional misconduct and the person is liable to have their license revoked. However, such changes and laws have not yet permeated into Ayush, that is Ayurveda, Unani, homeopathy, Siddha. They have not yet permeated the Psy profession, psychology, psychiatric, social work, etc. So, and they will definitely not permeate the religious authorities, because conversion therapy is also done through prayer camps and exorcism, etc. In fact, the state of Kerala, there are many such places where people take their gay children and their trans children, and they are, subjected to a lot of attempts by religious individuals to try and change their sexual orientation or gender identity. One person about 2 or 3 years ago from northern Kerala who was subjected to conversion attempts by psychiatrists both in Kerala and Tamil Nadu, put up a Facebook post saying that she was totally disoriented by all these therapies, and eventually she took her life. So as a result, an LGBT group based out of Cochin filed a case in Kerala High Court, and earlier this year, Kerala High Court also banned conversion therapy. After that, the Madras High Court thing came, and now the National Medical Commission thing has come. Directive has come. Yeah. Okay, so I see that there are feedback points, a feedback link posted by Sinia, but any other questions or reflections on from a more practical or less theoretical side? Yeah.
Sir, I think Ms. Musabiha have something to
Yeah,
ask
go
you.
ahead.
Hello, am I audible, sir?
Yeah, please go ahead.
Yeah, so my question is like how to handle these people with psychological, what is the psychological aspect which will they have, sir? Like psychologically, LGBTs will have a certain mindset and the counselor will be in a different mindset.
Yeah.
So how to handle these people?
Yeah, so first of all, as a psychologist or a counselor, the person has to understand, based on the World Health Organization and other authorities, that this is not a disorder. And the problem that people face from the community face because of anxiety or depression, etc., results from society looking down upon these people. So there is actually a field called queer affirmative psychotherapy and queer affirmative psychiatry, where there are some professional mental health professionals, some professional mental health providers who are running a training course in India called QACP. It's run by an organization called Mariwala Health Initiative out of Mumbai. And they have courses for psychiatrists, psychologists, social workers, etc., on how to not make assumptions about LGBTIQ people and how to provide therapy in a way that affirms the client's sexual orientation or gender identity without contradicting it based on a pathology model. And if you want some more readings on this, there are some papers, including a paper I've also written in a journal of psychiatry, so I can share with you some more references if you would be interested. Thank you, Musabiha.
There is a comment from Miss Maria Alice. Says like, I live in Brazil, and even though in our culture the LGBTQIA plus is openly discussed in schools and socially more accepted, strong prejudices are still observed even in medical terms.
Okay. Yeah, thank you, Maria Alice, for sharing this. Incidentally, when I was a student in the United States, my lab mate and closest friend was from Campinas in Brazil, and it's from him that I actually learned a lot about LGBTIQ. So yeah, there is that connection that I have very strongly with Brazil.
I think if there are no more comments, we can wind up the session, sir, as you have another session waiting for you.
Sure.
Thank you, sir. Thank you so much for joining us today. It was very, very enlightening session to us. Thank you all. We are very happy that you are here for us today. To all the other participants, thank you all for joining us today. I have shared the feedback link with you. Please fill it up, and I will see you on the next session on Friday. Bye.
Bye, everyone. Thank you.